A very good afternoon, everyone. It is with great honor and pleasure to welcome you all to this 21st Pediatric TB Eco Clinic in collaboration with the Regional Pediatric Center of Excellence for Tuberculosis. The Eco Clinic is a dynamic platform for case-based clinical discussions and dissemination of knowledge and bringing all experts together across the country for managing tuberculosis amongst children. On behalf of the National Institute of Tuberculosis and Respiratory Diseases, I would like to extend a heartfelt welcome to Dr. Sanjay Kumar Mattu, Joint Commissioner and Additional DDG, Central TB Division, the directors and representatives from NIRT, NTI, state TB officers and directors of STDCs, esteemed faculty members from medical colleges, district TB officers, medical officers, pediatric TB specialists, and all healthcare professionals participating in today's session. Now, please let me introduce the faculty from NITRD. I am Dr. Tulika Dhingra, Specialist Pediatrics at NITRD, and I will be moderating today's session. With me is Dr. Sangeeta Sharma, Chief in charge of the National Center of Excellence for Pediatric TB and also former Director of NITRD. To my extreme right is Dr. Alok Yadav, CMO NFSG and Pediatrician at NITRD. I would now request Dr. Sangeeta Sharma to please address the gathering and also welcome Dr. Sanjay Mattu, Joint Commissioner and Additional DDG, Central TB Division. Over to you, ma'am.
Thank you, Dulika. So, we are gathered once again for our monthly pediatric TB eco, which occurs on the third Tuesday, 2 to 3 p.m. So, we try to present interesting cases which have, lessons to be learned. And it's interactive session, and I want majority of you to pass on questions or your comments, and because always two-way learning helps us to improve ourselves. Now, I welcome Dr. Sanjay Mattu, who is in fact in charge of the pediatric TB program in the country. So Dr. Mattu has been at the helm of pediatric TB immunization program for more than almost like 15 years, maybe more. And we have been very closely linked together, being a member of the National Technical Expert Group, being a part of those guidelines, etc. So it's indeed a pleasure that we are in safe hands of Dr. Sanjay Mattu. Dr. Sanjay Mattu is the Joint Commissioner and Additional DDG TB. So, Dr. Sanjay Mattu, please, I would now request you to address this Pediatric TB Eco Forum, because your words mean a lot to the delegates, the spokes who have joined in. So, Dr. Sanjay Mattu, please.
Thank you, ma'am. Good afternoon to everyone. I hope I am audible.
Yeah, yes, you are.
Yes, sir, you are audible, sir.
Thank you. So at the outset, I would like to thank both NITRD team under the guidance and leadership of Dr. Sangeeta Sharma and ECO team for having this very good mechanism for sensitizing the issues of the pediatric tuberculosis to have the difficult to treat TB clinics. Like earlier we had in adult TB, and now under the guidance and leadership of Dr. Sangeeta Sharma, we are having for the pediatric tuberculosis also. We will understand there are the many challenges when we are dealing with the pediatric tuberculosis, be it what you call the diagnostic part or a treatment part and the preventive part over kids, which are a future of our country also. And if we are protecting them from the tuberculosis, this will be like great thing, and we are securing and making the future generation of the country healthy. Now, management of tuberculosis, you all understand in TB, in pediatrics is difficult because of there are some anatomical and physiological developmental issues are there with the pediatric age group. The diameter of the bronchi are less. They cannot produce the sputum on the command. So this is the diagnostic part. And then coming to the treatment also, we need to have the FDCs are different. Then we are having a dose adjustment, ADR management. These are all the some challenging aspects where we need to understand those things. And having this difficult to treat TB clinics for the pediatric persons, this will resolve many of the issues. And when we are having different topics, then it gives inputs how they can be managed in better way. And today's topic, we know that unmasking of the congenital immunodeficiency, which again, if the person is immunodeficient, then they are more prone to having the infection early and more prone to have the serious complicated tuberculosis form and even more chances of having a drug resistant tuberculosis. And today's topic, I hope that will be very good to understand how these situations may be managed. I wish all the best to both the presenter and the experts and all the audience who has joined on this forum for the learning. So I wish happy learning and good deliberation and discussion from Central TV division. We are with you all, and whenever you need any support, we will be there, and I will be listening through this session. And there might be some call from the ministry, so I may need to leave in between also. But till I'm here, I will be listening to the discussion part. Thank you, ma'am, and over to you.
Dr. Matthew, your work has mean a lot to us, you know. You're really truly the backbone of the pediatric TB elimination program in the ministry. So we do understand your professional commitments, but it's so encouraging that you have said that you'll remain with us till you get a call and you have to leave. So we do understand that. Now, Dr. Dhulika, please carry the session forward.
We have shared the link for the pre-test questions in the chat box. You may now attempt the pre-test questionnaire, the link of which is available. So today's presenting team is Department of Pediatrics at BJMC Medical College, Pune. And the presenter is, the case would be presented by Dr. Suhas L. and the didactic would be covered by Dr. Archana Pawar. The team of Department of Pediatrics, BJMC Medical College is led by Dr. Aarti and Dr. Pragati. Over to the team. Archana, you can share your screen. In case, okay.
Ma'am, is my screen visible?
Yes.
Yes. Just come close to the mic, Suhas. Come close to the mic. Yeah.
Good afternoon, everyone. I'm Dr. Suhas Yel, and this is Dr. Archana Pawar. We are third year residents from BJ Medical College, Pune. And today we'll be discussing a case of a 9-year-old female child who was born out of non-consanguineous marriage, first in birth order out of three children. She is a resident of Nigadi belonging to Maratha community with normal birth history, achieved all developmental milestones at appropriate age, belonging to modified Kuppuswamy scale class 4 socioeconomic strata. So, parents are separated since for the past 5 years, and history was given by mother, which is adequate and reliable. Till 8 years of age, the child was thin built, asymptomatic, and there was no previous hospital admissions and no chronic medical conditions. Coming to the course of illness, the patient first got admitted in April 2024 at YCM hospital with a history of fever for 2 months. And later, the second time, the patient got admitted at Sassoon General Hospital in the month of August 2024 with complaints of abdominal pain for 20 days, abdominal distension for 10 days, and swelling in the right elbow for 10 days. Moving on, the patient again got admitted for the second time in the month of June 2025 at Sassoon with swelling in the right distal thigh for 1 month. Later, the patient third admission at Sassoon was for complaints of progressive abdominal distension in the month of November 2025. So, coming to the history, the patient when got admitted at YCM in the month of April 2024, with complaints of fever, which was present for 2 months. It was intermittent, high grade, associated with chills and rigors, and was partially relieved on antipyretics and antibiotics, and it was associated with decreased appetite. On examination, the patient had cervical lymphadenopathy, chronic undernutrition, anemia, tachycardia, and hepatosplenomegaly. Uh, on the right side, as we can see on the growth chart, her weight was on the third centile, and her height was between third to 10th centile. Routine investigation showed low hemoglobin with low WBC counts. Blood, urine, and stool cultures were negative, and she was screened for TB, which was negative. Radio imaging showed necrotic cervical lymphadenopathy. Later, CECT abdomen with pelvis was done, which showed multiple splenic microabscess and pancreatic pseudocyst. That pseudocyst was measuring around 7 centimeter with imperceptible walls, with moderate to gross hepatosplenomegaly. Later, CT chest was done, which showed ill-defined consolidation, right hilar region, which you can also appreciate in the chest X-ray. And further investigation showed the rise in ferritin and triglyceride levels, and fibrinogen was low. And later, the patient was also suspected to have immunodeficiency, for which PID panel was sent. Here, as we can see, 5 out of 8 criteria for HLH was seen. So, considering it as secondary HLH, she had received dexamethasone and IVIG at YCM hospital. Since the fever was persistent, and to find out the focus of infection, BAL was done, which showed MTB, and it was rifampicin sensitive. So the patient was started on drug sensitive TB regimen, and eventually the patient took DAMA from YCM hospital. So after at home, the patient the fever was reduced, but the patient developed new symptoms of abdominal pain, abdominal swelling, and right elbow swelling. Her appetite had improved initially, but was later decreased. So, for the same complaint, the patient initially visited YCM, and suspecting multi-drug resistant TB, the patient was referred to Sassoon. So, the first time when she came to Sassoon in the month of August 2024, the patient was on CP phase of AKT with complaints of abdominal distension for 20 days. The distension was central, the abdominal pain for 20 days, which was central, intermittent in type, aggravated on food consumption, and relieved on bending forward. The abdominal distension was for 10 days, which was insidious onset, progressive in nature. It was seen more on the upper quadrant, and there were no aggravating or relieving factors. The right elbow swelling was for 10 days, which was insidious onset with local rise of temperature, and it was associated with tenderness and restriction of movement at the joint. So the right elbow sonogram was done, which was suggestive of acute osteomyelitis. So the USG guided aspiration was done, the pus was collected, and the pus culture was suggestive of MRSA. And the pus CBNAT detected MTB again, which was rifampicin sensitive. Later, the debridement was done, and appropriate antibiotic course was received. And further, the USG thorax and abdomen showed again the pancreatic pseudocyst with multiple splenic microabscess and mild left-sided pleural effusion. The pancreatic pseudocyst had now grown in size, which was measuring 9 cross 11 cross 13 centimeters, and the patient was advised follow-up for this pseudocyst to mature, and she was planned for surgery. For the multiple splenic microabscess, conservative management was done, and the line probe assay of BAL, which was done in April 2024, the culture, so the LPA, no resistance was detected in the LPA. So suspecting this could be iris, steroids was started, and the PID panel, which was sent at YCM hospital, showed isolated B-cell lymphopenia. However, since the patient was having active infection and disseminated TB, the patient was advised follow evaluation once the patient becomes stable. Once the patient was discharged, the patient continued to take AKT from Yamunanagar Government Hospital. Pune. The abdominal distension was persistent. However, no documentation of abdominal girth was available. So in January 2025, the patient again developed acute onset left knee pain with swelling, and there was no local rise of temperature, and joint movement was not affected. So the sonogram of the swelling was done, following which local aspiration of pus was drained with oral antibiotic on OPD basis. However, the bacterial culture showed no growth, whereas the pus CB net again showed MTB, which was rifampicin sensitive. The right elbow pus culture, which was sent in the previous admission, was received in January, which was negative. And in May 2025, because of acute onset right distal thigh swelling, the patient eventually got admitted in Sassoon in June 2025. As we can see in the image, the patient presented with right-sided distal thigh swelling, which was insidious onset. It was diffuse swelling, progressive in nature, extending from middle one-third to the lower one-third of the thigh. And it was associated with redness of the overlying skin, and there was local rise of temperature associated with pain. However, the knee joint movement was not affected, and there was no history of fever. So the MRI of the right thigh was done, which showed longitudinal intramedullary collection in diametaphysis of femur, extending to subperiosteal and soft tissue plane, again suggesting of acute osteomyelitis. So again, the debridement was done, and the pus bacteriology which was sent was negative. However, the CB net again showed MTB, which was rifampicin sensitive, and the histopath showed no granulomas or no acid-fast bacilli. The abdominal distension part, it was persistent. However, the USG now showed atropic pancreas with anechoic cystic lesion with multiple echoes, and multiple splenic microabscess were still persistent. The patient was advised follow up and continued AKT till the culture reports are available. At home, the right femur osteomyelitis debridement culture received in September 2025 was negative. So considering this, the AKT was stopped in September 2025. So totally the patient received 15 months of AKT, and the patient was planned for immunodeficiency workup. The patient did not follow up later as there was no active complaints. The thigh swelling had been reduced. There were no fever spikes. The appetite had been improved, and weight gain was noted. The patient eventually got admitted in Sassoon in November 2025 for progression of abdominal distension. So in the month of November 2025, the third visit to Sassoon, the patient came with complaints of abdominal distension, which was progressing more in the left hypochondriac region. It was not associated with pain. However, the swelling was moving with respiration. So CT abdomen was done, which showed chronic calcified pancreatitis with peripancreatic collection. And the pseudocyst was still measuring 9.1 cross 9.3 cross 11.3 centimeters with the wall thickness of 2.4 mm. The splenomegaly was present with splenic abscesses. The pseudocyst now was along right psoas muscle. It was extending to subcutaneous and intramuscular plane of anterior abdominal wall in the left hypochondriac region. The amylase and lipase were normal, and whole exome sequencing was sent as a part of immunodeficiency workup. So, the pediatric surgery had then advised to put pigtail drain into anterior abdominal wall swelling, and the pus was drained from the same swelling. The bacteriological culture showed no growth, and the CBNAT showed MTB, which was rifampicin sensitive. The same culture was later traced, and it showed no growth. Currently, the patient is in follow-up for pancreatic pseudocyst in pediatric surgery, where the patient is being planned for cystogastrostomy. The patient has asymptomatic abdominal distension currently. She is having good appetite, and she has gained 1 kg of weight since November 2025. Meanwhile, the younger sibling was screened and she was started on AKT on 1st of November 2025 as in view of radiologically diagnosed pulmonary TB. On examination, she weighs 20 kg currently, height of 120 centimeters, and BMI comes to be 13.8 kg per meter square. She is alert, and on examination, she does not have pallor icterus cyanosis, And as we can see, this is the picture when the drain was in situ, the Romovac drain in the left hypochondriac region, and the right elbow debridement scar and right knee debridement scar are present. Coming to systemic examination, abdomen appears distended more in the upper quadrant. There is well-defined cystic mass which is felt in the left epigastric region to left hypochondriac region. It is smooth surface, well-defined margins, cystic, non-tender, and moves slightly with respiration. And there is dull node present over the mass, and the bowel sounds are normal. So this is the immunodeficiency panel, which was sent in YCM initially, where we can see the lymphocyte count is decreased, uh, mainly the B lymphocytes. However, the NBT and DHR part of the panel showing the neutrophil functions is normal. And this is the whole exome sequencing of the patient, where it is showing otolin gene mutation, uh, which is autosomal dominant with immunodeficiency 107, susceptibility to invasive Staph aureus infection. So the take-home message from this case presentation is a positive CBNAT report is not a contraindication to stop AKT, as CBNAT can detect even a DNA of a dead bacilli. And in patient with drug-sensitive TB with unresolving symptoms and showing negative cultures, so alternate diagnosis should be sought. Meanwhile, the patient is taking AKT. And prolongation of AKT in patients with unresolving symptoms without any evidence of active TB infection, it usually increases the pill burden, it leads to poor compliance, and also increases the side effect of the drugs. So investigation always aid management, but in complex or atypical case presentation, it is always the clinical presentation which must lead decision making.
Good afternoon, everyone. We already have heard all the cases regarding this immunodeficiency. So I will be.
Archana, just a second. We'll pause here so that in case there are any questions from the house, we can first take them and then we can go ahead with the discussion.
Okay.
Yes, ma'am.
So, if there are any questions from the audience, we can take them up now. Questions related to the case. Any questions from the audience? Okay, so if there are no questions,
Okay. So, case is very good, but I think that is not routinely found in these cases by the TB DTUs and other people. I just have one question, two questions. After the treatment of the 15 month of this child, the treatment I think initiated by the YCM hospital when the child was admitted in April to June in 2024. So what is the
Yes.
current status after when you given the ATT for the 15 month is what is the status of abscesses and the last abscess which was in the right thigh swelling from where you get the CBNAT and culture was also found negative. So
Yes, sir.
after the before stopping the TB drugs, what is the status of abscesses, thigh abscess and any other?
Sir, the right elbow
ਇੱਕ TFT
swelling.
ਹੁੰਦਾ ਫਿਫਟੀ ਦਾ ਟੈਸਟ ਹੁੰਦਾ ਉਹ ਕਰਾ ਲਓ ਆਪਾਂ ਹੁਣੇ ਫਿਰ ਦਵਾਈ ਦੇ ਦਿੰਦੇ ਉਹਦੇ ਹਿਸਾਬ ਨਾਲ ਉਨੀ ਕੁ ਦਵਾਈ ਦਾਂਗੇ ਜਿੰਨੀ ਜ਼ਰੂਰਤ ਆ
Sir, the right elbow swelling and the thigh swelling, they were drained by surgical team, and currently there is no recurrence of abscess there, and the joint movements are present, and there is no recurrence of symptoms in those sites, sir. And after receiving 15 months of AKT, the appetite of the patient is improved, and there is also noticeable weight gain. And currently, she does not have symptoms other than the abdominal distension, which is due to pancreatic pseudocyst. And she is eating well, and her weight gain has been noted of around 1 kg since the after stopping AKT. That is since November 2025.
what is the role of the particular ubiquitin gene in this child, particularly for this child?
Sorry, sir, I didn't hear the question.
In this particular case, why you do the whole genomic sequencing in spite of giving the ATT, child was improving. So I just want to know, and TB, MTB were detected from 2024 to 2025 November. CBNet was coming positive. So why you think to do the whole genomic sequencing in this case?
Sir, even after starting AKT, initially the patient had pancreatic pseudocyst and splenic microabscess. But even after starting AKT, if it was per se due to tuberculosis, she would have improved. Again, there is recurrence of symptoms like elbow abscess and thigh abscess. So and when we were following up the patient, the cultures were always negative, sir. CBNAT might be positive, but the cultures were always negative. So, and also there was not a significant improvement in the patient. The symptoms were still persistent regarding the abscess. So we had to think of alternative diagnosis. That is why we were thinking of it of in the line of immunodeficiency.
You know, few comments to make. And a question to you. What led you to continue ATT for 15 months?
Sorry, ma'am.
What led the team to continue ATT for 15 months? Did you do blood sugar? Did you do HIV? You know, the algorithm which we follow for a case who's not responding. This is for the information of the journal house. You know, whenever we have a case who is not responding on ATT. So there are two things which need to be kept in mind. Two kind of scenarios they can exist. One is a clinically diagnosed TB, you know, but the other is the microbiologically confirmed, as was in this case. This case is a microbiologically confirmed TB, drug sensitive TB, because the CB-NAT was positive. So, in case of clinically diagnosed TB, there is always a doubt which is there that it could be an alternative cause of the disease. So, always keep that in mind that, you know, especially for clinically diagnosed TB. In case of microbiologically confirmed, few things they need to be taken into account. Number one, when a child is not improving, you need to do a blood sugar, you need to do HIV, because these are two things. And SAM, as was in your case, the child's weight was third centile, height was between 3 and 10 centile. So always, you know, improve the nutrition of the child because these things they need to be taken into account. And the most important is that you need to check the compliance, whether the child is taking the medicines or not. In this case, the regimen, etc., they appeared. I think they are. No, I mean, as per the NTP and the WHO regimen, the doses we have the weight band table. I think that has already been checked. Yes?
Yes, ma'am.
Yeah.
Yes, ma'am.
In case the child is not improving, then you also need to think about a more common thing, that is that your blood levels of the drugs. So there comes the role of total drug monitoring. That is what we call as the TDM. You've seen cases where, you know, everything is in line, but the child is not improving because of the poor absorption of the drugs. Then the other thing which needs to be kept into mind is even, you know, co-administration with antacids, because antacids that decrease the absorption of the ATT. So these are in general which I am trying to tell. And obviously, you also thought about PER, that is paradoxical upgrading response, what we call as the TBRS. Now,
Yes, ma'am.
because in case you are, microbiologically tests, they are not helping us, it could still be, and you started steroids. Now, in case of PER, your child may develop new lesions, But the general well-being of the child, that starts to improve because the immunity of the child is now getting better. That is the reason, that the response of the body is TB iris. And last is always keep in mind about MD or drug resistant TB or MDR. So in this case, you have ruled out drug resistance because it was drug sensitive. What I can see, you got a first line LPA. So the first line LPA, I have a question on that. How could you do a first line LPA without doing a culture on an extrapulmonary TB specimen? Because the bacterial, the colony count has to be more than 10,000 bacilli before LPA can be put. But what I think your LPA was done without a culture on an extrapulmonary specimen. Although it can be there, it can be done if the bacterial, the colony forming count is it's touching nearly 10,000. You can still do LPA on the extrapulmonary TB sample, but that's a very rare entity, so it has to be culture positive. So I just want to ask you, was it culture positive because the first line LPA was done?
No, ma'am. It was the culture was negative, and we did it on the sample of CBNAT.
See, sample
It's
you
a
cannot do
BAL.
it.
It is a BAL sample, no? So
Ball sample you cannot do it. Ball sample, as I'm telling you, LPA requires the minimum requirement is 10,000 bacilli. That means it has to be smear positive. Was the ball smear positive?
Uh,
Yes?
Bal's smear was positive, ma'am, initially.
Okay. That is a possibility. If the smear is, I think we have an echo at our end. So if the bar smear is positive, then in case the ball smear is positive, then the LPA can be done. So that was the reason. But smear was positive, but the culture never came out positive at any time in your case.
No, ma'am. The culture,
Even the
since we,
initial culture was negative. The ball initial culture.
yes, ma'am.
Because
The
see,
initial
I
culture
think
was also negative.
people go back because you may recover it sometime later. This is what I'm trying to tell. Go back to your laboratory, ask them because everything is recorded in the under the Nikshay platform. I'm sure this child must be having a Nikshay ID. So
Yes, ma'am.
although all the reports would be entered into the system, it's always better to keep a record of those reports because they might be, because there is a real chance with this immunodeficiency that there may be, recurrence of TB. Okay.
Yes, ma'am.
So,
Yes,
but
ma'am.
I must congratulate you. You thought of something unique, and the diagnosis it turned out in your favor. But for the general information of the house, this is a very rare condition. Try to rule out the common things first. That is the most important thing, that rule out the common things first. Had this child been with us, we would have done the drug levels because the PK blood levels, they are more important. Had the levels been normal, then I would have started to think about the rare things. After that, the culture never came positive.
No, ma'am. The culture was negative and never
I
positive.
wish you that please go back and ask for these reports. These are very important reports because culture is a good guiding principle. And always, the other thing I would suggest is that whenever you are sending the specimens, like you send the specimen from the osteomyelitis, always, sending and following appropriate SOPs of extrapulmonary TB samples is very, very important. And I've been stressing upon this time and again. Please, you need to divide your sample. Take two slides, make two dry slides. They need to be sent for the ZN staining or the rhodamine or with LED. Then wet slides in formalin. They will be guiding us about the caseating granulomas because if the caseation is not there, could be an indicator, indirect indicator that your patient is improving. There were caseation initially. All these things they guide you later in your management. Initially it was caseation necrosis. Now the caseation is not there. There is fibrosis or even calcification. So these are indicators that the child is improving. So always send 2 dry slides in for ZN, 2 wet slides in formalin, and the major chunk of the sample needs to be sent in normal saline. And with the saline sample, what the lab does, they do a NAT test, be it CB-NAT or an indigenous TrueNAT, and a smear. Now, if the smear is positive, then they can do a direct LPA, that is first line LPA in case of drug sensitive TB. And if it is rifampicin resistant, then they go ahead with the second line LPA. But if the smear is negative, then and precious samples also. Please request your lab in case of precious samples that always put a culture, because the chances of picking up the organism are maximum at the start of the treatment. So these are a few things which I think they are useful in clinical practice, and we need to follow these. But excellent, you did a good effort and you came out with the results, and you picked up a rare condition, that is immunodeficiency. So I think we can. If there are no questions, we go ahead with the discussion. Who's to present the discussion? Dr. Archana, discussion.
Yes, yes. As we can see, we have already discussed this case. So coming to immunodeficiency. So my lecture is on unmasking the congenital immunodeficiency through the tuberculosis in childhood. So we are discussing only the immunodeficiency part in the short. So what is immunodeficiency? So immunodeficiency is a state in which the immune system's ability to fight an infectious disease is compromised or entirely absent. So it is broadly classified into 2 categories. One is primary and other is a secondary immunodeficiency. So like when to suspect the primary immunodeficiency. So according to European Society of Immunodeficiencies, PID is to be suspected if 2 or more of the following signs are present. First one is the 4 or more ear infections within 1 year. Second is the 2 or more serious sinus infection within year. Then if the child is having 2 or more months on antibiotic with little or no effect, then if the child is having 2 or more pneumonias within 1 year, and if child is not gaining weight or is not growing normally, then if he is having recurrent deep skin or organ abscesses, if having persistent thrush in the mouth or fungal infection on the skin, or requiring IV antibiotics to clear an infections, and or if the child is having 2 or more deep-seated infections including septicemia, and more importantly a family history of PID, this should we always be thought if child is having 2 or more of the following signs, we should go ahead with the PID workup. Basics of immunology. So what is immune system? Immune system is our biological mechanism for identifying and destroying a pathogen within a large organism. So what is the pathogens? Pathogens is our agent that cause diseases like bacteria, viruses, fungus, and parasites. So there are 2 types of immunity, one innate immunity and the adaptive or acquired immunity. So why the PID diagnosis is so difficult? Because most of the child do not have abnormal physical features. Then if we are using antibiotics, that might mask the presentation of the PID, and most children are routinely are not getting screened for the PIDs. So these are the classification of primary and secondary immunodeficiency. This slide showing the primary immunodeficiency based on the affected component of the immune system. As we can see, if the humoral immunity is affected, then we can think about of the diseases like common variable immunodeficiency, then selective immunodeficiency like IgA, transient hypogammaglobulinemia or X-linked hypogammaglobulinemia. If the cellular immunity is defective, like problem is with the T cell, then we can get diseases like chronic mucocutaneous candidiasis, DJOR syndrome, X-linked lymphoproliferative syndromes. If we are getting combined humoral and cellular, like both the T and B cells both are defective, then we can think about ataxia telangiectasia, hyper immunoglobulinemia M syndrome, severe combined immunodeficiency, and Wiskott-Aldrich. If there is a phagocytic defect, then we can think about chronic granulomatous, Chidiac Higashi, cyclic neutropenia, and leukocyte adhesion defect. And also there can be a complement deficiency which is affecting C1 or terminal complement like C5 to C9. Secondary immunodeficiency might be because of some systemic disorders like diabetes, HIV infection, and malnutrition. If the child is on any immunosuppressive therapy, receiving cytotoxic chemotherapy, bone marrow transplant, radiation therapy, and corticosteroids, and if the child is having any prolonged serious illness, uh, some key points that we should not miss in the history taking, like we have to ask for the frequency of fevers, there any associated symptoms, whether the patient achieve normal state of health in between that episodes, how is the response of the antibiotic of the children, then family history of recurrent infection or multiple hospitalization among the family members, or is there any history of any previous infant or childhood death in the family, how is the scholastic performance of the child or developmental history, then social interaction of the child, and detailed dietary history we have to ask. Then also during newborn time of the umbilical cord separation, whether child is having any history of bleeding tendency and history of any blood transfusion and adverse event caused because of that transfusion. So if we are suspecting immunodeficiency, so first initial workup that we have to go ahead with we have to ask detailed history and physical examination, and after that we can go ahead with the complete blood count with the differential count. According to that culture and imaging we can get, and we can go ahead with the IgG, IgA, IgM, and IgE levels. And if we are suspecting any infection, we can get a titers according to that, like diphtheria, tetanus, pneumococcus, and hemophilus. And also we can get a complement level also get done. If all above investigations are normal, then we have to consult with the clinical immunologist and we have to consider the following. Like if we are suspecting phagocyte defect, then we have to test like a dihydrorhodamine for chronic granulomatous. Then we have to go ahead with the flow cytometry for LAD1, LAD2. Then consider a neutrophil chemotaxis assay. If we are suspecting humoral defect or if we are suspecting combined defect, then we have to go ahead with the flow cytometry for T cells, B cells, natural killer cells. And also we have to enumerate the percentage of nerve memory and switched memory B cells. But as we can see, these are the so many tests. We can't advise these many tests for to get diagnosis of the PID by. So we can get a specific type of infection. We can suggest which can suggest the effector arm of the immune system that may be dysfunctional, and test can be applied based on the targeted fashion. So if child is getting recurrent, we can see the B cell, T cell, phagocyte, and complement affection. We can get, if the B cell is affected, recurrent sinopulmonary infection, enterovirus like bronchiectasis, and recurrent gastroenteritis. We can get the antibody titers, vaccine titers, and lymphocyte flow cytometry. If there is a phagocytic defect, then child will present with the abscesses, adenitis, severe bacterial infections, poor wound healing, and periodontal disease. Then we can get neutrophil count oxidative burst test. If we are suspecting T cell defect, the child will have failure to thrive, pneumocystic infection, candida infection. Then we can get the lymphocyte count done and lymphocyte flow cytometry for T cell proliferation. If we are suspecting complement defective, then we can get a recurrent Neisseria, early onset lupus, and encapsulated bacterial infection. Then we can get complement level done, like complement and alternative pathway complement level. So coming to our report, which we got like immunodeficiency 107 in this case, which is susceptible to invasive staph aureus infection. So what is this report tells us? So this is autosomal dominant inheritance. Molecular basis wise, it is caused by mutation in the OUT ubiquitinous with linear linkage specificity gene. And immunology wise, we can see that child is immunodeficient, but child will always have normal leukocyte count, normal immune cell function, and normal level of immunoglobulins. The defect is in the innate immune response, which rises in the fibroblast. So disease onset is in the first decade of life, which is having incomplete penetrance and variable expressivity, which is characterized by invasive and severe life-threatening infection with the staph aureus affecting the skin and or lungs. So clinical presentation wise, there might be having severe invasive skin or lung infection, necrotizing cellulitis, furunculosis, abscesses, community-acquired pneumonia requiring hospitalization, and sepsis. One of article has suggested that autoimmune haploinsufficient patient with severe tissue necrosis could get benefit from a combination of antibiotic and steroid therapy, as well as from the monoclonal neutralizing antibody against the staph aureus alpha toxin. So coming to this patient scenario, treatment wise, we thought we can go ahead with the clinical history and examination, finding and investigation. We have already counseled the mother regarding the report that we got through whole exome sequencing, and because that is an uncertain significance, so child will require that need for parental testing. And so meanwhile we are treating that abscesses. Patient is in close follow-up with us, and also along with the pediatric surgery, and also will consider as a prophylactic antibiotic therapy once that there is a resolution of that abscesses. Once the infection and inflammation subside, and if the parental testing is possible, patient can be considered for the immunomodulation therapy. So my take-home message is this case will require high index of suspicion, do screening test and appropriate additional test as required. Early diagnosis and prompt treatment could be life-saving, and we have to teach this immunodeficient patient how to avoid infection and how to require preventive measures that they have to follow. Thank you.
Are there any questions from the audience after this discussion?
Archana, you can stop sharing.
Yes, ma'am.
One or two in the chat box. Can you guide some immunodeficiency which is the most common found in the TB patient, basically, na? How to approach the TB patient if you think immunodeficiency also? Can you? Can you give some?
You want
So,
me to
Dr. Aarti,
Yeah,
I think
okay.
we need your help.
Yeah, I thank you, ma'am, for giving us this opportunity to present. What questions you asked, madam, in the beginning, they all came to our mind. As an Indian, we first doubt whether compliance was good. So the first two admissions went in finding out about the compliance. It's a disturbed family. Mother, father are divorced, and the mother is bringing up. So always the doubt of compliance comes. But we did the pill count and the normal things in the program which help us to identify. That was the first thing. The second thing was patient was already suspected of a immune deficiency because of the bacterial infections which happening recurrent. Every time osteomyelitis was showing CBNAT positive, drug sensitive, but cultures were negative. And the treatment got prolonged because it takes time for the culture to come. We had to wait for six weeks every time. The child used to be admitted, treated, sent home, and during second admission we were getting the reports of the culture as negative because they were plating it and trying to make sure that it is really negative. So gradually it went on extending. The next part which happened is one of the BAL showed drug sensitive, CBNAT positive, but again the cultures were never helpful for us. So once the child started improving and the culture came negative, we decided to stop and see under close observation. So that was the time when we realized that under observation, if we stop and if there is no improvement, then we might consider again reinvestigating for MDR or some resistance which is there. And even to get the whole exam, we had to actually arrange for the funds because it's not routinely available. And once we got it, it was in the last admission that the report came after discharge, and then we had to call back. So from November till now, patient is clinically improving as far as her appetite, overall health, weight gain is concerned. So as far as the patient is concerned, we don't have a definite answer. The child will remain with us for follow-up, maybe for a year or two or even longer. Then we looked at the literature to see how long the CBNAT can remain positive. So there are various reports way up to 7-8 years also you can get the CBNAT positive, and some of them have said 3 years, 5 years. So it depends on actually the original case, what it was and how bad the infection was. So right now the CBNAT positive is not suggestive of an infection, though we may be wrong in that. You asked a question about drug levels. We could have done that. We did last time when we presented a case, there were a lot of indications to do the drug level. Maybe we could have done it in this to help us with the compliance. That there was always a doubt, but if the levels were normal or they were low, then in that case, we should consider whether the absorption and metabolism of the drug is normal, especially with this child with that pancreatic pseudocyst. So there is some malabsorption which also may have been there. Routinely, we check for HIV, which is negative in this child. The second one was sugar levels. The sugar levels are normal in this child in spite of the pancreas being affected. And even one of the ultrasound showing a little atrophic pancreas. As of now, the sugars are maintained. So those were routinely done, but I am sure, I think Dr. Suhas and Archana should have presented and told that it is negative. So we'll keep that in mind. What is more striking is this, the younger sibling of this girl was actually put on 6 months treatment of INH, and it did not work in this child until we saw that the X-ray is showing changes. So then we again had to screen the entire family members and the people coming in to see if there is any undiagnosed active case, especially the older family members, but there are only 3 of them living together, but they do have visitors. So the younger sibling is now on anti-TB drugs as a part of full treatment. And if this is autosomal dominant, then one of the things we have to do is arrange fundings and get to do the whole exam in them to say that it's a family with this immune deficiency and more proneness to bacterial infections like staph. So this is what we thought about, and the first report from YCM, they had suspected a PID. So that report came almost 4 to 5 weeks later, and it showed lymphopenia as well as the absolute count was low. So I think one of the thing is always keep on thinking, if they don't, the TB patient doesn't follow a routine this algorithm, think of all these things, and with some funding and some massar, we are nowadays able to do the whole exome sequencing in about 10,500 to 12,000. We are able to get it done, but we will not tell that do it routinely. Okay.
Yeah, the basic purpose of the discussion is that the message should go across that this is one of the very rare scenarios. So, as I said, what really needs to be done in clinical practices, send all the available samples, and I've already shared about the SOPs of proper extrapulmonary TB samples, how they need to be sent. Also do blood sugar, HIV, because this is for the general information of the house. And the only thing which I suggested was that the culture, if it was positive, as initial culture said that it is positive, so that detailed report of that culture would be important. And it would be available with the NICSHIP, under the NICSHI ID. So it's, in a sense, important to retrieve that for records also, because I'm sure this child might have recurrence later on, because there is an immunodeficiency, and this immunodeficiency is going to stay, for life, because there is nothing, from my information, I don't think there is any radical treatment which is available so that this immunodeficiency is cured. I don't think so.
No, ma'am, there is no
Oh,
treatment as such. We just have to watch and treat the infection. and prevent it. The two options is that to put on antibiotic prophylaxis, which also we felt was not the right thing. How long? Because there is no mention how long you will continue. And the second is immune modulators if we find that these infections are life-threatening. That this time they were all bone infections which we were able to manage by with antibiotics. Hello. The voice is breaking, madam.
The parents, asking about the parents.
Parents are normal. Like the father and mother are separated, but we did get the history. They are healthy. They are like tall, thin people, but no infections, nothing. They have been the same like that, but they are all tall and thin patients, all the family members.
And any workup for the MSMT Mendelian susceptible mycobacterial diseases regarding IL-12 interferon gamma axis? Any workup was done for this patient? No, ma'am. Your voice.
You're muted,
ma'am.
Unmute. Please unmute.
Okay, we can plan to do it. The patient is under follow-up, but we'll just have to talk with the laboratory in Mumbai, KEM hospital, and if they are doing it, or the private labs where we will have to arrange for the funding and then get it done. But if you have any laboratories who we can send the sample, we'll be more than willing to do that, who will do it at concessional rates or free of cost. Then we have got a set of investigations which we would like to consider in the near future. Because still we don't have an answer, sir.
Next. Please enter the child. No, Delhi.
Okay.
You can write on the medical superintendent there that and request that this is such and such case. You can write a case summary and request them because they are routinely doing these tests. So whenever we send to AIMS Delhi.
Okay, we'll try that, ma'am. We'll write it. Thank you.
Any other question?
Any
We can't hear you. Can you unmute, please, sir?
in these type of patient, can you suspect NTM also in the PID, particularly in the primary immunodeficiency cases?
Yes, sir. The panel which was sent to KEM, ICMR Center in Mumbai, actually they did the 3 sets of tests. So except for the B cell low counts, the rest of the cell tests which were available with them are all normal. So we'll again have to be in touch with them to do exactly this panel because they don't do it in their whole set of panel. The report which we showed you, sir. But
I think the question is that CBNAT is does not it is negative with NTM. So it takes up MTB complex. So the complex has those 5 bacteria. M. bovis is one of them. So if you have a BCG adenitis, so that will be NAT positive, but not NTM. So MOT is positive.
this child's CBNAT has always come positive, madam.
So
Like
CBNAT is positive.
yeah.
So that is the reason I say, yeah, it's okay हो रही है. You know, we are.
मैम के मैम से 2 डिवाइसेस से जॉइन
कौन? नहीं, जब मैं बोलती हूँ तो हमारे यहाँ एक
मिनट मैम रिसीव करेगा.
Dr. Aarti, I would request you that you please remain logged in with a single device because that's creating echo. You can.
There is only single device here in my room. I am sitting in a separate room.
Because because there is a echo.
अभी होगी
ठीक है.
अभी म्यूट हो गया नहीं हो रही
So the 5 bacteria which are a part of the MTB complex, one is Capri, one is Bovis. It could be that is the reason I suggested that please retrieve that culture also. The initial culture which is positive, because that will give you the result. And the other thing is, like, first line LPA was positive. So LPA is also indirect marker of if it has a tub band, so that shows that it is MTB and not MOT. Although then you have a confirmatory LPA for MOT, which is different. That is a different LPA. That is also LPA, but it is meant specifically for NTMs. The first line LPA which we do is that is for MTB that has got a tub band. So these are answers to look. Any other question or any other comment?
There was a hand raised by STDCWB. They had raised the hand.
Good afternoon, madam. This is STDC, West Bengal. One clarification, or rather, thing which I wanted to know from you was that a pregnant mother being treated for tuberculosis, drug sensitive, and she delivers, and the baby is directly put onto oral BCG at the first vaccination. Is it not mandatory, or is it not needed that the baby should be screened for whether is having active TB?
Yes. So the guidelines for newborn are that you need to rule out congenital TB.
Yeah.
Because in that case, ATT would have to be started. The other thing which is important is, if the chances of the child having active TB, they are also depending upon the kind of TB the mother is having. If the bacillary load is high or the ATT was started late. So these are the children, based on the Cantfield criteria, that they have higher chances of developing congenital TB. So a child who is born to a mother with the TB during pregnancy, first and foremost is that you need to rule out active disease in the child by doing a general examination. We just forget doing the general physical examination of the child. If the child is born low weight, IUGR, it could be an indicator that the child suffered from any congenital infection. And the other thing is get a chest X-ray, ultrasound abdomen, because the primary focus could be in the liver. And then also send a gastric aspirate. Can send a gastric aspirate for everything, for NAT, for culture. And once you are sure that there is no TB in the child, then you need to start INH prophylaxis depending upon whether the mother has drug sensitive TB or drug resistant TB. If the mother has drug resistant TB, then you need to start 6 months of levoflox or moxiflox depending upon the sensitivity. And BCG vaccination we do not withhold till the completion of 6 months of INH, or because although we do realize in our country we do not have INH resistant BCG available. INH resistant BCG is available in few countries but not in ours. But in our scenario in our country, we recommend to give BCG because there is a definite role that BCG has, that is, it prevents the dangerous or the disseminated forms of the TB disease. So we recommend that if, you need to give BCG in the beginning or whenever it is possible at the earliest occasion. And the last and the foremost is that the mother needs to continue giving breastfeeding with a face mask until and unless she is sure that now she is sputum negative. So face mask is very, very important, and proper disposal of the sputum of the mother. So these are all those airborne measures that need to be in place.
Yes.
But these are the, in nutshell, the guidelines of management of congenital TB.
But is there any guideline, madam? There is. I don't think there is
Yes,
a guideline.
these guidelines are available www.tbcindia.org. All these guidelines, the pediatric guidelines, they are there. Then the other thing is that we made those, ICMR standard treatment workflows for pediatric TB. I would request, people who are interested in pediatric TB to go through and, even read through that, because all those the standard treatment workflows of ICMR, that was a Herculean task which was done by so many experts throughout the country, and that document is really a very good resource. It has everything. So you can even consult that. Then the guidelines, as and when they are updated, automatically the updation happens on the website. That is tbcindia.org.
That. Thank you, ma'am.
Any more questions before we wrap up today's session? The guidelines are available on tbcindia.org. So if there are no more questions, we'll wrap up today's session. But before we wrap up, I would just like to summarize briefly whatever we discussed today. So whenever there is a child who is non-responding, we need to look for the causes of non-response. And as we've discussed, we need to first look out for the common causes, confirming the diagnosis, checking for the compliance, checking the drug dosages and the drug levels. If we can do that, we have to rule out drug resistance. At the same time, we have to ensure that we have checked the blood sugar levels and have ruled out HIV infection as well. As in case, like in this child, we saw that the child had history of multiple infections. There was failure to thrive. We were having evidence of Staph aureus infections at multiple sites. In such cases, immunodeficiency may also be one of the reasons for non-response. And also, we need not forget that every time we have a patient, we need to do contact screening as well. Just like it was done in this case, they were able to find out the sibling being affected by tuberculosis. And the third important message that we take home from this discussion is that CBNAT may remain positive, because it may detect the DNA from dead bacilli, so it may be positive for 3 years to up to 5 years. It is not used for follow. So at the outset of the disease, CBNAT, the NAT is useful, but not for follow-up. For follow-ups, cultures are important. So with this, we wrap up today's session. But before we do that, I would request Dr. Ashok Bhardwaj, Chairman, National Task Force, for his closing remarks.
So thank you, Sangeeta Madam. Thanks, supported by Dr. Yadav and Dr. Dhulika. So I congratulate Dr. Aarti for excellent comments and Dr. Archana for enlightening us for immunodeficiency in tuberculosis. So it was wonderful because I was in Ludhiana reviewing medical college, so I could not listen the full course, but I listened all session of immunodeficiency by Dr. Archana. So thank you all. Thank you all the participants for regularly joining this pediatric eco clinic, and hope in future also everybody will join. So thank you very much. Thank you.
So we need support from the medical colleges to log in. I've been always
Yes,
reminding.
I am trying my level best. Every time
Yes.
I write
Because I think it's a
send
good
mail to
resource.
all pediatrician.
It's a good resource, especially because the kind of cases we present, they are a bit high level.
It's very
So
important.
because that
Very,
is
very
the
important.
feedback, yeah. And I think the residents in pediatrics, they would
Yes,
be
yes.
gaining the maximum out of us.
It's
So
very, very important for them. Very, very
yeah,
important
yeah,
for them.
yes, yes.
Thank you.
So, Dr. Dhuli.
Yeah. Thank you, ma'am, and thank you, sir. I would request everyone to please attempt the post-test questionnaire as well. We have shared the link for the same in the chat box. So we will be closing today's session, but the meeting will be on so that you can attempt the post-test questionnaire as well. So with this, I take your leave and thank the team from BJMC Medical College for this enlightening case. And I would like to remind that the next TB Eco Clinic is on 17th of March, and the presenting team this time would be AIMS Rishikesh. So till then, goodbye, and we will see you again for an interesting case discussion in March next month. Goodbye.
Thank you.
Thank you.
Goodbye.
Thank you.
Thanks.